Good evening. Myself, Dr. Santosh, inviting you to attend Dr. K.K. Karwal Med Talks. This is the 594th episode on role of probiotics in PPI induced small intestinal bacterial overgrowth. We have our eminent speaker, Dr. Setu Pu, senior consultant gastroenterology and hepatology, KIMS Hyderabad, HOD Gastroenterology, KIMS Hospital, Governing Council member of National Board Examination. We welcome
Thank you
Dr.
very
Setu
much.
Babu, sir.
Thank you
Yes, sir.
very much.
Yes, sir. Today's one of the most important and one of the most asked question is like, what is SIBO? It is a name itself is little confusing also for our family physician because it is coined in that way. So, what is it and how it is manifest in your patient?
Uh, Basically, I think this is one particular syndrome where it's self-explanatory. There is a bacterial overgrowth. Normally, there is a set gut microbiome which is there in every human body, and this is distributed across the small and large intestine. It's only esophagus, stomach because of the high acid pH that you don't have bacteria. Right from duodenum, there is a bacterial flora distribution, and as you go down, there is a significant change in the forms of bacteria, and more gram-negative bacteria tends to accumulate as you move distally. There is very interesting symbiotic understanding between the gut microbiome and human health. In fact, they do help in digestion, in absorption, vitamin synthesis, bowel transit. So there is a huge impact. As and when you get a change in the bowel, let's take the best example where we see this is either an inflammatory bowel disease or an irritable bowel syndrome, very commonly known conditions. There is a significant change of these gut microbiome. You do studies and do a microbiome called mapping, then you find there is a significant change. This is one area. Second one is there's something very exciting that happened is we know the fatty liver or the NASH or NAFLD, which we refer. There is a specific microbiome in NASH which makes them to develop NASH. Similarly, alcoholic hepatitis. There are two very good studies which have shown disease specific gut microbiome. So, whenever these bacterial flora are disturbed due to multiple reasons, though I gave introduction as these syndromes, there is an excess of coliform growth and the favorable bacteria, which includes say, lactobacillus species, they get suppressed. So you get change in the bacterial flora. So this is referred to as a small intestinal bacterial overgrowth, and it has a negative impact on the human body.
Yes, sir. So that means you are saying there is a hormonal relationship or equilibrium in the intestine, and there is any change in the equilibrium, it will leads to a excess amount of bad habit.
Right.
That's what. Yes, sir. But
You
yes, sir.
so whenever there is a disease or whenever there is a change, for example, the simplest thing is when you consume a lot of antibiotics, for example. Again, the bacteria gets destroyed and new bacteria tends to grow up, and there is an imbalance between favorable and unfavorable bacteria, and this imbalance makes them a true definition of small intestinal bacterial overgrowth, and it is a detrimental effect.
Yes, yes. Sir, what are the factors? Because it will important to for the clinician or the patient to understand what are the factor it leads to this kind of a problem. Maybe it is a internal that we call the interior organ or extrinsic something like a surrounding area. So what are these factors?
I think you take to put it both in a one way. There are a lot of factors which will change this one. Let's start with, for example, the commonest is usage of drugs. This is something which changes the entire environment too broadly. Second is one which cause motility disturbances. These motility disturbances are varied and they could cause again a significant change. We also have, for example, post surgical syndromes, a lot of post-surgical syndromes. For example, there are people who have got a gastrojejunal bypass, or currently there are a lot of obesity surgeries which are happening. All these things again cause bacterial bypass actually, leading to bacterial overgrowth. So there are a lot of diseases. For me, the best example, if I have to give you, is the irritable bowel syndrome from the standard point of view, and inflammatory bowel disease like ulcerative colitis or Crohn's disease. These are some of the commonest things, but we blame drugs as one of the important cause of disturbed bacterial flora in the system.
There's some comment section of comment here. The doctor is asking. So because our stomach there is a pH value is very less, that is the acidic, and in the long into till colon, the it's a pH value. So in between there is so much of organism. So how can we understand that whether it's a good or bad? Because acidic and alkali. So there may be a, they are saying that whether the bacteria in stomach is harmful in bacteria in colon, or how it is managed by the body, or how it is probiotic will help in this.
Interestingly, I think the best example would be, suppose somebody takes PPI. The gastric
Yes.
pH normally is around 1.8 or 2, and the moment you give a PPI, it grows to 4 and 5. Normally, stomach does not colonize bacteria for two reasons: acid pH. Second, there is a constant motility. Unless you consume food, the stomach doesn't have any, it's almost empty every time. So, because of the constant gastroduodenal emptying, you don't get bacterial colonization in the stomach. It's around the down the duodenum bacterial colonization starts. So stomach cannot contain a bacteria. That is why whenever you want to do a small bowel bacterial overgrowth culture, you actually do a small bowel intubation across the duodenum, goes into the duodenum, and then draw the fluid and represent. They are also called something like a jejunal cultures or deep duodenal cultures. Then you get rough value of the organisms, and they tend to vary as you go down.
Yes, sir. There is like whatever summarized, like maybe gastric acid or the motility or the GI secretion or the peptides, or these are the factors which
Common.
is there inside. And extrinsic, of course, diet and PPI you just told, or any other NaCIDs, it will help reduce, increase the. But what about the symptoms? Like which are the commonest symptoms patient come to the doctors, especially in a clinical setting?
Actually, it's very difficult to differentiate between somebody who's got a SIBO and somebody who's got a disease. But the best thing is most of them have something called a dyspeptic symptoms. It starts with something like a gas bloat syndrome, or some of them have anorexia as a predominant presentation. Some of them can have diarrhea as a predominant presentation, and there are some people who become anxious because of these symptoms. So I think most of the time a SIBO syndrome is an overlap syndrome with multifaceted presentation, right from dyspepsia to abdomen bloating, gas bloat syndrome, to altered bowel movements, and they can get borborygmi. So these are some of the common symptoms when you start suspecting that, yeah, there could be an underlying SIBO.
So what are the risk factor, like any comorbidities which may associated with SIBO? Any condition?
Yeah, I think the diabetes is the most important cause. In diabetes, you have something called autonomic neuropathy, which affects the diabetic, intestinal motility. Most of the diabetics, if you ask them, they might say, "Yes, I have dyspeptic symptoms. I have gas bloat syndrome," and they could have an underlying SIBO. Difficult to prove, but then what we do is we do symptomatic therapy and try to see whether they get back their symptom in free intervals.
Yes. Sir, what are the types of SIBO? Because doctors sometimes it may be sometimes constipation also, sometimes diarrhea also. So what kind of types of SIBO you come across in your practice?
I think most of them are diarrheal type. If you say roughly, there's a 50-50%, I should say. Or there may be about 10 to 15% who have got a mixed type or variable type. It's similar to irritable bowel syndrome. You got somebody predominant constipation, Somebody can have a predominant diarrheal component, or there could be a mixed combination. Let's say somebody who has got a diabetes and who is taking cardiovascular medicines, and then he could come with a dyspepsia bloat syndrome, and he has episodic diarrhea, or he says sometimes I get constipation. I think that's a typical syndrome where you can suspect that he has an underlying SIBO. The second group is somebody had some infection, they've taken an antibiotic. So there is something called post-infectious, SIBO-like syndrome or irritable bowel-like syndrome. They do overlap, in fact. So these people, again, after a course of antibiotic, they could come to you with a dyspeptic symptoms or gas bloat symptoms. They could also again have SIBO underlying with them. So most of the presentations are dyspeptic, and antibiotics is the one which we need to. Diabetes is the most important motility disorder we consider, and post-surgical. I think if they have a gastrointestinal surgery, and they have, we seen, for example, patient who had an obesity surgery, and they come to you with symptoms of SIBO as common.
Common cause. Yes, sir. You are rightly said. There is a diabetes capital of India with lot of diabetes patients. So there is a definite chance, along with this, any motility disorder or the colic or the any surgery or the NSAIDs or maybe anatomical disease that are the causes of SIBO. That's one of the commonest, even though it is one of the commonest, how to diagnose this?
I think it's very difficult to diagnose because we need to prove. I think the ideal way is somebody has to do what is called a duodenal bacterial culture, which is not normally done. But you can use some breath tests, which we do in our hospital. We do hydrogen breath test. There's some another test, methane. Methane is not normally used, but you could actually differentiate a methane related SIBO or hydrogen related SIBO. But we mostly diagnosed hydrogen breath test, which is a simple, or in some people we do urea breath test, which is again another test which we do to prove that there is some kind of an underlying malabsorption and SIBO as a common component. But let me tell you, ideally, most of the people do not resort to doing tests, but they do a clinical or conjunctural correlation and say, okay, this fellow clinically likely to have a SIBO. Let me try some medication. Should somebody has got a dominant SIBO, should I give them luminal antibiotics? Or yes, still a SIBO, can I change the balance using probiotics? That's where you get a discussion on clinical grounds.
Yes, sir. It is definitely, it's a diagnosis is difficult, but sometimes the breath test also it is going to help. So, but the in the treatment, what is the main parameter any physician has to understand? Because this is a commonest, but definitely this is very difficult to diagnose. So, what kind of treatment you will suggest?
Uh, I think if the patient is not exposed to an antibiotic before, he's a diabetic, and he comes to you with alternating diarrhea, constipation. There's some, we put them actually in the bracket of, say, irritable bowel syndrome slash SIBO. And there is a trial of rifaximin which is permitted, 7 days of rifaximin, followed by we try to use a probiotic. So one of our schedule is give them 1 week rifaximin followed by probiotic. There is another couple of trials which have shown primarily give them probiotics and change this one. I think individuals vary, but there is a large group which believes that probiotics could be helpful in these people.
Sir, one of the questions asked from the doctor is rifaximin is probiotic?
No, rifaximin is not a probiotic. It's actually a luminal, non-absorbable antibiotic which kills majority of gram-negative bacteria. I think another best example is in hepatic encephalopathy, where patient goes into hepatic liver-related coma. We try to bring down the gram-negative bacteria which cause ammonia production by using rifaximin. So another very important, with a similar objective of using rifaximin, is hepatic encephalopathy.
Yes, yes, sir. You give the nice principle of managing the diseases. Like there's an underlying. You told the underlying diseases. So first we have to manage the underlying diseases, and
Yes.
then we have to go for whatever the overgrowth. We have to reduce it or eradicate, and we have to give the nutrition. So in underlying, you said diabetes, so it means that if I take the diabetes has to control, then whatever the overgrowth, we have to take the rifaximin. But how
True.
to address the nutritional deficiency?
Uh, I think probiotics basically are not nutrition. They, but what they do is, of course, there I should correct myself saying there are some probiotic bacteria which actually produce B12 as one of the component. So, though they are not nutritional, they may not be supplemental, but they could help in the digestive process by changing the bacterial mechanisms. So there are people, for example, in a diabetic patient is on oral anti-diabetics. Adding probiotics, will it help in control of sugars? Theoretically, yes, it could help in these, at least a subset of people who could probably have our underlying bacterial overgrowth could be helped. So one indication would be this. In our routine practice, what we do is irritable bowel syndrome, where the patient comes, we diagnose that there is no organic disease. We do not resort to checking their bacterial flora of the bowel, but with the available knowledge, we do give them probiotic as one of the main treatment along with anticholinergics as an antispasmodic. I think there the indication is very good, and there are randomized controlled studies, particularly in irritable bowel syndrome where it's a motility disorder.
Yes, sir. So that means you are keeping the probiotics in eradicating the overgrowth and nutritional in between, and you will treat the patient accordingly. Then coming to this, one of the question they ask, fecal microbiota transplant. It is there, the word is there, but what is it and how it is benefit?
I'll tell you, the extension started long back. That originally a healthy fecal matter is seen, say around 50 grams to 100 grams. You put a duodenal tube and inject these in fresh stools through the duodenum. The landmark paper published in Lancet about Clostridium difficile infection is really provocative. In fact, there is a 90% remission rate in a refractory Clostridium difficile diarrhea. Subsequently, there was a lot of interest to use this in inflammatory bowel disease, and few centers have actually tried, and it was quite exciting to replace. In fact, there are dry fecals capsules are made available, oral pills are made available. You know, it looks very silly or funny that you pack some fecal matter in the form of a capsule and give it as an enteric release is interesting. FMT gave good results in few areas, and this includes probably inflammatory bowel disease. There are some studies, particularly from Kerala. There is one center which has used in alcoholic liver disease. Fecal microbial transplant has helped in relieving the hepatic encephalopathy. I think this area is a little open, and for multiple reasons, it has not become very popular, but the concept is very popular.
Yes, sir. So with this, definitely there is SIBO and there is a probiotic. There is a definitely the correlation and there is a benefit of. So coming to this probiotic, there is a lot of species you come across in this. Which species which you prefer, or the single species or multiple species of?
And this is, yeah, this is never an unanswered question. Even today, we do not have, some. There are some in the market. There are almost about 100 preparations. Now, there are few preparations which require cold chain. There are some which are freeze dried, and some which are actually in the form of a powder and sachets and these things. The pediatric use in infective diarrhea is highest. In adult diarrhea, more than for every diarrhea, probably many physicians would like to use it as a standard protocol in every diarrheal disease. We do not have really good evidence, but there is one good paper published in acute gastroenteritis in pediatric practice. Probiotics help. Answering your question, does a single viable bacteria help, or does multiple bacteria help? I think the logic of using multiple bacteria could be slightly better than single bacteria, but I don't know. I'm not aware of any comparative study of using single high quantity versus multiple quantities. The second thing is the dosage of these bacteria is, again, there is no clarity which is the right dose and all. The favor is in terms of using lactobacillus species seems to be quite interesting. Suppose if you look at simple analysis of all the available probiotics, the lactobacillus seems to be the most prominently used in every formulation.
Yes, sir. So there is a definitely benefit of lactobacillus. Any benefit from streptococcus or clostridium in as a probiotic?
I'm not aware of a particular paper, but what happens is, honestly, if you tell me in an open forum, the probiotic prescription is more subjective than an objective.
Okay.
We do right. The indication seems to be much more clearer than using X or specific one. For example, earlier there is a landmark paper of using a lactobacillus species, particularly in ulcerative colitis, which is actually distal proctitis is benefited. This is a first and probably the most important landmark paper, which was published in gastroenterology long time back. First paper. The second two datas have published from, I think this is from Lucknow. No, sorry, this is from Ludhiana. I'm sorry. This is from Ludhiana. Two good papers have been published where they have used, particularly lactobacillus species, they have used multi bacterial combinations, and it has helped in ulcerative colitis very much. So if you ask me the question, yeah, it is the physician's choice, physician's experience of using continuous single species versus complex species, multiple. If you look at pediatrician, probably they are more happy with a single species.
Yes, sir. Sir, there is a one interesting debate. There's like there is a spores and there are also say live bacteria. So there's a continuous debate, like same thing, multiple spore or single. So what is your suggestion? Spores is it better or live bacteria? Is it?
No, I think the problem or the interesting thing with spore is they're easily, can be stored even in dry uh, or heated area. The logic that spores go, they become vegetative, and they give the benefit effect for a transient and then passed out. I'm aware of one small study where they gave spores, did the stool exam, again the spores were there. But in between, did they do anything? We really do not know. But we guess all the spores, when they become an environmental friendly, they become vegetative. They do help whatever the probiotic favorable actions, which includes nutritional support, vitamin support, digestive support, or motility support, and they pass off. They become, once they reach the colon, they become spores. This logic is acceptable, but I'm not aware of any particular proof. There is also one more issue that comes is you give large quantities of vegetative bacteria. Some of them tends to actually die in the passage, but the remaining quantities again actually flourish. They regrow. They become again become almost a culture-like environment. They grow, they help, and then they again pass on. There is one study which is the curve which was shown. Let's say that I gave today 10 million units of or they call it colony forming unit, CFU. So let's say 10 to the power of 4 or 10 to the power of 8 bacteria which I gave, they increase the colony count. You go on checking this fecal matter up. Once dose can go up to 10 days. After 10 days, again it falls. So I was actually suggesting, does intermittent use of probiotics, could they have any action? Is a absolutely a point of debate. Looks an interesting logic.
Yes. There is one some interesting. Yes.
Last one. There is, I think, the Scottish group. They actually are, dairy products. Most of these Scotland countries, they are actually on dairy farm. They seem to have a robust health compared to other parts of the world, simply because they use lot of dairy products. So proving the fact, yes, probably it helps.
Yes. Yes, this is come to the answer for the question. One of the doctor asked how to improve the large intestine with a good bacteria, like what kind of food, fermented food, and you give the example in a European countries example.
I think a bit, semi-sour curd is supposed to have lot. We have the National Institute of Nutrition in Hyderabad. They did some studies and have shown that the curds which we use conventional, when they are half the stage, not completely sour, because that is a lactic acid. These bacteria produce lactic acid and make the milk more sour. So if you have the curd which is early curd, they will have more lactobacillus than the sour curd which contains lactic acid.
Okay, yes. So there is a question like usually the typhoid fever, it is mostly affecting the intestine, and there is a role of probiotics after complete typhoid treatment.
Yeah, I think the logic is extremely good, but I'm not aware of any particular study. But as I told you, these are the people who are exposed to a lot of quinolones, which are the drugs. For example, the treatment of typhoid still stands today. Quinolones and quinolones cause destruction of the normal flora. So it's a very good logic that you supplement following an antibiotic therapy seems to be a good logic. I don't belong to the school where we say we give antibiotic plus probiotic. We do believe in a sequential therapy. You treat whatever is the primary condition, let it be typhoid, let it be an acute gastroenteritis. Then you start supplementing the probiotic. It's a good logic.
Yes. So there is a questions on that probiotics and malignancy. There's a lot of paper come up. So what is your intake on this?
Now, I think this is what is a very good, particularly colon cancer and gastric cancer, the two good studies which are published. The logic appears to be quite good because they make the favorable bacteria, and the metabolism is even the chemicals which cause malignancy are also neutralized by these probiotic colonies. The logic, if earlier we used to take one aspirin a day to prevent cardiac attack. I think today one probiotic a day might be a good logic to prevent malignancy. But I think long time is the most evident. Should we prescribe families who have got colony cancer probiotic? Interestingly, yeah, they can try actually, but it's not a recommended use.
Yes.
The
Sir,
answer seems
regard
to.
yes, yes. Sir, you just mentioned about the prevention of the cancer. So what happened? Already the patient have a cancer which is using chemo and radiation. So radiation enteritis is one of the cause. So what is the benefit of
Again,
probiotics?
there are quite a good number of publications that probiotics do help and reduce the intestinal injury on people who used this one. Very recent paper actually shows that radiation enteritis is prevented by using probiotics. Similarly, people who are on chemotherapy, what happens because of the powerful drugs, there is a huge change in the intestinal microflora. So, by giving a favorable flora once again, which is rich in streptococcus or lactobacillus, there is a therapeutic advantage, or it helps in early healing and all. The logic is very good, but the proof is still, I mean, if you do a randomized controlled study and do not give probiotics to group X and give probiotics group Y, the Y may fare better, and that logic works. The most important point here, probably before we close or something, are probiotics safe? That is a $1 million question. So currently, the data shows, except there are a couple of systemic lacticidemia, which is a bacterial infection, the probiotics in general are safe. They're usually not absorbed. Most of them do not get absorbed, and they have very little negative impact. And that is one reason. Uh, Today, if you ask me, should I replace vitamin supplementation with a probiotic? That seems to be a good answer, but don't take it as a recommendation, just a suggestion.
Yes. Sir, before closing, I want to ask one or two questions because this is one of the questions mostly asked. Patient have a diabetes and they are saying complain of the same symptoms, whatever you discuss. So
Yes.
probiotic will help And what is the duration of probiotic in in a chronic diabetic patient?
So let me. I think I should confess what I am doing, which is not evidence based, but it's an experience based. We use intermittent probiotics. We use a multifaceted organisms. Intermittently, we use because what happens, the colonization happens quite often, and most of the diabetic seems to be happy with this, but this is not the main treatment. So you need to look at the main control of sugars and look at their autonomic neuropathies and their drugs, and everything has to be looked in, and this forms one of the co-prescriptions. I think that's a better word to use. And probably intermittent vitamin therapy or intermittent probiotic therapy could be a good logic, but scientific evidence is lacking. But experience, if you ask me, the answer seems to be yes.
Yes. So regarding this test, you already told the doctors are gut microbiome test, whether it is available or whether this test is really helpful.
Yeah, there is something called 16 DNA studies, which has actually does the DNA nucleic acid studies, but it is really scientific research and not done routinely. And there is one company which actually does your microbiome mapping. They charge you, send a diurnal aspirate to them in a this one, and the cost, I was quite surprised. I won't tell the company, but then they're doing something like 25,000, and this test is available. They do somewhere in upcountry, and the microbiome mapping is done. But at the end of the day, either you are left with using an antibiotic or probiotic, which is subjective. But my suggestion would be sequential therapy in the form of use the antibiotic for their primary condition, followed by probiotic, which, if I'm permitted to quote, will be an intermittent probiotic therapy is much more useful than taking a pop or popping up a pill every day as a this one.
Okay. Sir, there is a last question I will ask you,
Yeah,
but I know it is the
no
question
problem.
is something like psychological issue, whether probiotic help to reduce psychological issue.
Yeah, there is a very interesting this one. Those people who got, for example, take SIBO for example. In SIBO, you do CNS studies. It shows that these people are anxiety and they have some element of depression or a combination of both. There is also one study, offhand, I'm not able to quote, where people who are with depression, there's a psychiatric people, when they were given probiotics, there is a relative improvement. This is an objective paper which was published. So I think there is some role, whether it is a gut hormonals or gut favorable peptides that make a change. Should we use people who have got anxiety, depression, along with their primary treatment? Probably the answer is yes. But remember, whenever we are recommending probiotics, the primary treatment for which we are treating should be the priority, and probiotic would be, quote unquote, is a beautiful supplementary approach to the whole problem.
Yes, sir. Sir, after all the discussion, I come to know that gut is the control of the body. Like whatever we are eating and all, it is in directly related to our future complex or comorbidity. So, gut health is one of the most important part of our day-to-day routine. So, before closing the session, I want highlights or whatever the summary
Let
which
me,
you want to.
I think, let me, a good gut is much better than millions of brain cells.
Yeah, yes, sir. That is
Is
the
what.
right word. Yes, yes, sir. So, yes, before closing, I want your suggestion or whatever insight you want to give to our doctors.
So I would say that probiotic is a favorable drug. Using in the right conditions, identify your condition. You take any article or any book on this one, it says, okay, probiotics are useful in a long list of conditions. You take any textbook of medicine, it gives long. There are some specific conditions where there is an intestinal motility disorders or where the gut motility is disturbed. People who are on chemotherapy, people who are on cancer and diabetics and all. We do prescribe probiotics until there is an evidence. Intermittent probiotics do help in reducing the disease, or at best, as I quote unquote, is the best supplementary that we can use for the future.
Yes, sir. Thank you, sir. Thank you, Dr. Seth Babu, regarding in detail discussion and what the important insight on role of probiotic in PPI induced SIBO. So I thanks IGCP, and this program is sponsored by YBAC and YBAC DS from USC. Thank you, sir.
Sure. Thank you very much.
Thank you.